Hello, my name is Elizabeth Altenhofen. I'm a nurse practitioner in the doctorate program at the University of South Alabama. My DNP project is urinary biomarkers for the earlier detection of advancing acute kidney injury among sepsis patients. The purpose of this project was to implement and utilize structural urinary biomarkers, which are the TMP2 and the IGF-BP7, to detect acute kidney injury earlier than the functional biomarkers, which are the BUN, creatinine, and urinary output, among patients that are admitted to the critical care unit with a diagnosis of sepsis, to reduce the advancing stages of acute kidney injury by 20% within a 2-month period. The 3 objectives for this project include educating all of the medical ICU staff about the project and its expectations during the implementation, utilizing the NephroCheck test, which is the urinary biomarkers, on all patients that are admitted to the medical ICU and have a diagnosis of sepsis, and for this patient to experience 20% less occurrence of advancing acute kidney injury. I did a survey prior to the implementation of this project to determine how much knowledge and information that the staff had concerning acute kidney injury. And the survey results showed that most nurses were familiar with one aspect of either rifle, KDIGO, or AHN, but they had no clear definition of what acute kidney injury was. And during my research, I found that surveys that had been taken at other facilities came up with the same results. Of course, after the project was completed, the staff was more aware of what acute kidney injury was, its criteria, and its consequences for the patient. I've included a slide to show the definition of what acute kidney injury is, and for this project, and I utilized the KDIGO, which was based on serum creatinine and urinary output. Acute kidney injury among sepsis patients. The most common complication is acute kidney injury. 50% of critical care patients develop it, especially during that first week. And of that 50%, 13% will require some type of renal replacement therapy, whether that be CRRT, PERT, or intermittent hemodialysis. Some of the short-term and long-term complications include lifelong renal replacement therapy, after discharge, a decreased quality of life if that were to happen, while they're in the hospital, an increased length of stay, and of course a progression to either chronic kidney disease or end-stage renal disease. It's also been found that among Medicare patients, hospital readmissions were at a 33% likelihood. The mortality rate for these patients is 24%, and if they are placed on some type of renal replacement therapy, that increases to 50%. And as you can see in the next statement, that sepsis is the leading cause of AKI among critical care patients. The global healthcare cost for acute kidney injury ranges from 4.7 to 24 billion. Nationally, that cost is approximately 88,000. If they are admitted to critical care, that number doubles. And if they require some type of renal replacement therapy, it increases by 11,000 to 42,000 per hospitalization. And of course, I have statements here that show if they have AKI and they do not require renal replacement therapy, the increase in healthcare costs still continue to go up. The best strategy for reducing acute kidney injury healthcare cost is, of course, reducing the incidence of AKI. Healthy People 2030, they had an objective to reduce the new cases of end-stage renal disease. They determined the baseline was 386.7 among a 1 million population. They had a target goal of 290 new cases. In 2018, the most recent data showed that they had not reached that goal, that they were at 378.2 new cases. Although they believe it's improving because it was still less than what their baseline was. Their target setting method includes maintaining programs locally that implement strategies to prevent AKI on a consistent basis. The International Society of Nephrology is a globally focused initiative. The goal was to reduce or eliminate AKI deaths by promoting local preventative programs for AKI. There was a snapshot study that was done from 2016 to 2017. It included approximately 96 countries, and the purpose was to identify any differences between AKI recognition, management, and any outcomes based on those two. They found that there was no standard protocol for early detection of AKI, nor was there a standard treatment for AKI. So the initiative 20 by 25 AKI was developed. The NephroCheck test includes 2 urinary biomarkers. The first one is the tissue inhibitor of maltoproteinase 2, or the TMP2, and the insulin-like growth factor binding protein 7, or the IGF-BP7. Both of these biomarkers are secreted by the kidneys during the early stages of cellular damage. These are 2 of the best performing markers for detecting renal injury before there are changes seen in the GFR, the serum creatinine, and the urine output. They act as a warning signal for tubular cell stress. Acute injury progression for AKI. As you can see, right when there is an increased risk, the kidneys will give off the TMP2 and the IGF-BP7 biomarkers. This is the time for early intervention. Once the damage is done, the serum creatinine increases and the urinary output decreases, and the GFR decreases as well. By this time, these symptoms are considered late markers. Here is the NephroCheck scoring that was used during the implementation project. If the NephroCheck came back greater than 0.3, it was considered to be positive, and the patient would develop moderate to severe AKI within the next 12 hours. If it was less than 0.3, it was considered negative, and the patient would not develop AKI at least in the next 12 hours. The plan for the doctorate project implementation included when a sepsis patient came to the emergency room and was admitted into the medical ICU. Upon admission to the unit, the patient would have a NephroCheck test done. If it was negative, the staff would continue along the sepsis pathway. If it was positive, then the staff would continue not only on the sepsis pathway, but also include some renal protective measures. And this would be renally docile medications, especially antibiotics. Maintain that MAP greater than 65 so the kidney has its perfusion. Provide some hydration with IV fluids. Closely monitor electrolytes, serum creatinine, urinary output, and if need be, consider consulting a nephrologist. The data that was collected during the implementation of the doctorate project included the nephrocheck, or the urinary biomarker results, creatinine, and urinary output. 16 patients were captured. Of those 16 patients, 69% were positive and 31% were negative. There was one patient that tested positive and then subsequently developed advancing AKI. On day 2, the patient was given a diuretic, and subsequently the AKI stage 1 resolved by day 5. Some of the limitations that occurred during the implementation process were inconsistent documentation of urinary output, poor compliance with implementing the nephrocheck test, and resistance from some of the staff members during the project, even though initially there was acceptance of the project prior to implementation. Some future considerations include electronic alerts. This is something that can be added to the sepsis order set. It helps remind the healthcare provider on the prevention and actions that are needed for AKI. Also, studies have shown that electronic alerts that are coupled with treatment or preventative measures, they reduce mortality by 20%, and then they reduce advancing higher stages of AKI by 50%. Another consideration would be annual education for all staff members on AKI prevention so that they have the latest information. I would like to thank everyone for listening to this presentation of my doctorate project. I would especially like to thank Dr. Joseph Ferry and Dr. Hannah Sullivan for their guidance and for their advice on my project.